The Subcommittee on Employment and Workplace Safety will come to order. Today we're discussing healthcare workforce, specifically how we can revitalize and reinvigorate the workforce we will need for the next several decades. Ranking Member Braun, who is even more of an expert than some of our panelists in his own way as an employer. Ranking Member Braun and I will each have an opening statement. Then we will introduce the witnesses. After the witnesses have given their testimony, senators will have 5 minutes each for a round of questions. While we are unable to have the hearing fully open to the public or media for in-person attendance, live video is available on our committee website, help.senate.gov. Senator Braun and I have invited members outside the subcommittee to participate in today's hearing, and we will look forward to them being a part of this conversation as well. There's no doubt that during the pandemic, healthcare workers have worked tirelessly on the front lines and faced, in many circumstances, unimaginable challenges. However, the critical needs of the healthcare workforce were here before and will extend well beyond COVID unless we act. The Association of American Medical Colleges estimates that we will face a shortage of up to 124,000 physicians by 2034. We'll also need to hire at least 200,000 nurses per year to meet the increased need. Just in Colorado, we're facing an estimated shortage of 10,000 nurses over the next 5 years. We're also facing a critical shortage of medical support staff, like medical assistants and nursing assistants. If we're going to make a dent in these daunting estimates, we need to get started now. I'm glad to welcome our excellent witness panel, who are themselves working tirelessly to make progress in creating a pipeline of talent to take us into the future. We need to improve the recruitment, retention, and upskilling opportunities of our healthcare workers. If we are serious about growing the field, we should make it easier for those without college degrees, for working parents, and for those without previous experience to break into early-stage healthcare jobs. For those who are in mid-career and wanting a change, we should allow more opportunities to upskill and progress forward. And we need to recognize the importance of having a healthcare workforce that looks like America and brings diverse experiences to the medical field. We need to increase diversity and representation among healthcare workforce to reflect the communities that they serve. One way is to invest early in expanding STEM education and mentorship opportunities for students in the health professions, particularly students of color. Healthcare can be a vibrant, rewarding profession, but we have to give today's healthcare workers and future healthcare workers opportunities to learn and thrive and grow at every level. If we want to combat the current burnout and build a robust, diverse workforce in the future, this has to be a priority. I can't think of a topic more important, and I look forward to hearing our witnesses' testimony about how we can make progress in the weeks and years ahead. We've gotten so much outreach and interest in this hearing, which really does show what a pressing issue it is. I'd like to ask unanimous consent at this point to enter 13 letters into the hearing record from various organizations, including letters from the American Academy of Family Physicians, National Nurses United, and the University of Colorado, among others. No objections? Whew, good. Now I will recognize Ranking Member Braun for his opening statement.
Thank you, Chairman Hickenlooper. This is an interesting discussion for me because since I've come to the Senate, the high cost of health care, especially from the point of view of an employer. I had my own business for 37 years, and it was so small for so long, shared it with some earlier, that it wasn't really a concern. It got to be, as we grew from 15 employees into that next and most recent 20 years, 300 and now 1,250. 3 of my 4 kids, along with a good young executive team, run that business. I stay closely in touch with it. Healthcare has been navigating through a lot of challenges. When you look across the world, we spend about 18 to 20% of our GDP on healthcare. The rest of the world has similar, if not better, outcomes, in some cases for half that cost. We were in the throes of that challenge, and then you get hit by the biggest pandemic healthcare challenge. It really shows a system where its weaknesses are. I can't talk about it today, but I think beyond what we're going to try to focus on today, healthcare has got to be a priority for the healthcare consumer. When I changed my plan 15 years ago, most individuals weren't interested in prevention and wellness. They were interested in remediation at whatever the cost was. I flipped the paradigm upside down. I think the industry has catered to mostly remediation. And I think it needs to focus as we get through shortages in workforce in offering the healthcare consumer more information about how you avoid the system by staying healthy and prevention. It's the underpinning of what I did, in addition to making my employees healthcare consumers. Let's look at where we are now. In December of 2021, 10.9 million job openings. About 15% of these openings were in the healthcare industry. On the front line, had to put up with this formidable foe that we had no idea where it was going to take us. In October of 2021, a report by Morning Consult found that 18% of healthcare workers, imagine that, quit their jobs. You can see why. They were there having to put up with the uncertainty of how this was going to work out. 31% thinking about leaving. I mean, most businesses can't take abruptly a 5% exit, let alone this. When you look at shortages like this, it's always worse in some places. And I come from a state like Indiana. Many of our states have a rural component. We found out we don't even have rural broadband in most places when you need to have it when you're working away from home, or even in as it relates to healthcare. So it involves other issues as well. How do we get through it? How do we get workforce in the place that's been most ravaged by the events, healthcare industry itself? I think it's going to take an interesting combination of the healthcare industry, hospitals, practitioners, insurance companies, even pharma, to know that you're going to have to take some of the burden yourselves, that you can't rely on government to do this. And when it comes to how we educate our healthcare workforce, we got to look at that in the same way as we are many other areas. In my home state of Indiana, pre-COVID, we had probably 60 to 80,000 jobs that couldn't be filled because we weren't guiding our kids in middle school and high school to maybe look at the opportunities. We were stigmatizing many of these pathways that don't require a 4-year degree. My experience in my own business is when we have a 4-year degree opening, we get flooded with applicants. We need better life skills, better guidance in those most formative years, and I think parents would buy into that. They've had enough issues of a kid going after a 4-year degree ending back in the basement when maybe they would have needed just other common sense options put out there. So I think that across the board, we spent a lot of money, $178 billion to the Provider Relief Fund. It will take more than just spending money. That's what we do best here. We borrow 23, now up close to 30% of it. We have to have better ideas that are hard to arrive at a solution. Most of us in the real world don't have a printing press in the basement, and we've got to do it with limited resources in the rigor of competition. I think government's got to take some of those cues in terms of what we need to do better. So I'm glad we're having this hearing. Workforce is an issue across all states. It's now the biggest deal, the biggest issue in the biggest sector in our economy. And when you look at the percentages of how many have left, how many are considering leaving, we got to make sure we're at least coming up with some good ideas and not necessarily just spending money on the problem.
Thank you, Ranking Member Braun. I appreciate that. I appreciate that perspective. Now what we'll do is allow each of our witnesses to have 5 minutes. And at some point, Chair Murray will be here, and we'll let her do her opening statement when she gets here as well.
And Senator Hickenlooper, will I have the opportunity to introduce the witness?
You certainly will.
Thank you.
You probably have a busier schedule, so I'll even let you go first,
Well, thank
Senator
you.
Cassidy. So why don't I turn it to you for that member privilege?
I appreciate that consideration. Thank you, Chairman Hickenlooper and Ranking Member Braun. It is my honor to introduce Dr. Rayno Verret, the sixth president of Louisiana Xavier University, one of Louisiana's historically black colleges and universities. Dr. Verret is a proven leader in higher education, fostering an innovative university environment to address underrepresentation in medicine and other fields and to respond to the workforce needs of today. Dr. Verret is also an accomplished biochemist and immunologist. If you look at his tie, I think that's the periodic table, which I know that Senator Hickenlooper would recognize. He participated in the COVID-19 vaccine trials and has been a vocal advocate in my state for folks to take the vaccine. From the start of the pandemic, Dr. Verret and Xavier have worked with local health agencies and hospitals to host mobile testing centers and to set up a fully operational COVID-19 testing lab to serve local communities and Xavier's campus. Before being president of Xavier, Dr. Verret was provost at Savannah State and Wilkes Universities, a dean at the University of the Sciences in Philadelphia, faculty and department chair at the chemistry departments of Tulane University and Clark Atlanta University, and an adjunct professor of immunology at the Tulane and Morehouse Schools of Medicine, and has conducted cancer research at MIT. As a former academician, I'm impressed with that resume. But I would say that Dr. Verret's leadership throughout the pandemic has been equally or more impressive. Dr. Verret clearly understands the challenges facing HBCUs in today's environment and the urgent need to address underrepresentation of racial minorities in the medical and health science fields. I am pleased to have worked with Dr. Verret on my bill with Senator Schatz, the John Lewis National Institute on Minority Health and Health Disparities Research Endowment Revitalization Act that would provide additional funding to HBCUs to research health disparities and to promote the diversity and strength of the science workforce. We need leaders like Dr. Verret to speak to the challenges, to plot the way forward, and to help find solutions in recruiting a larger and more diverse healthcare workforce. With that, I yield.
Thank you. Appreciate that, that warm introduction. Now I'll take over again for two introductions, and then we will revert to Senator Braun for the last introduction. First, I'd like to introduce Dr. Margaret Flinter from Middletown, Connecticut. She's the Senior Vice President and Clinical Director of the Community Health Center, Incorporated. She's Chair of the Board of Directors, National Nurse Practitioner Residency and Fellowship Training Consortium. And I think it's fair to say that over these many decades, she has helped transform the Community Health Center Incorporated not only into one of the nation's largest federally qualified health centers, but one of the most innovative health system networks of any category in the country. And I remember firsthand when they first began doing telemedicine back in the 1990s, before it was common, and certainly when it was difficult to be able to do any billing for it at all. Anyway, thank you so much for being here, Dr. Flinter. Next, I'm going to introduce Norma Quinones. She's the Nursing Services Manager for Clinic of Family Health in Lafayette, not Lafayette, Louisiana, but Lafayette, Colorado. She's the site coordinator for the National Institute of Medical Assistant Advancement, NIMAA, Ms. Quinones started working at Clinica in 1992 as a medical assistant and has served in a variety of leadership roles. And I know for a fact that she is one of the people that holds Clinica together and helps them succeed in one of the most challenging and diverse, geographically diverse as well as diverse among people, healthcare systems in the West, and certainly in Colorado by a long measure. As I said, she's from Lafayette, Colorado. I love the fact that she's next to Dr. Verret. We have the Lafayettes kind of grouped together. We're delighted to have you here, Ms. Quinones. And now I'm going to turn the last introduction over to my friend from Indiana, Senator Braun.
Thank you. You'll also be hearing from Rachel Gressler, a research fellow in the Economics, Budget, and Entitlement Center at the Heritage Foundation. Her area of focus is on labor and retirement policies, and previously served as a senior economist on the staff of the Joint Economic Committee of Congress for 7 years. Thanks for joining us today, Rachel. I look forward to hearing from you.
Perfect. All right, so we will then start, and Dr. Flinter, why don't you start, and then we'll go right down along the table.
Perfect. Can you hear me?
Yes.
Perfect. Well, good morning, Chairman Hickenlooper, and members of the Senate Health Committee and members of the Employment and Workplace Safety Subcommittee. Thank you so much for having me here today. I hope to convey to you in my few minutes the urgency of the healthcare situation and to identify strategies that are working and that we can build upon. Primary care is in a crisis, as you've already alluded, between burnouts, early retirement, an aging workforce, and competition with other medical specialties. As Senator Hickenlooper said, we're headed for a predicted shortage of almost 130,000 physicians by 2030. And at the same time, the aging of the U.S. population, the impact of complex and multi-chronic illness, and the persistent health disparities that we are also aware of, all combine to make the need for every individual, every family, every community to have access to high-quality primary care ever more important. And the National Institute of Science, Engineering, and Medicine's landmark 2021 report, issued just a few months ago, has laid out a blueprint of what needs to be done. Where is the next generation of primary care providers going to come from? I answer, it's already here. Nurse practitioners are here in number and in their focus on primary care, but they want, need, and deserve the opportunity for postgraduate residency or fellowship training, similar to what their colleagues in medicine, dentistry, and other health professions have enjoyed, in order to prepare for practice and settings in which the nurse practitioner is the bedrock, the core, and the foundation of primary care. So today, I want to speak to what we're doing to address this and what remains to be done. I'm going to focus on primary care providers today, but my comments are also relevant to psychiatric mental health nurse practitioners and to the specialty care and hospital outpatient setting and inpatient setting. So 15 years ago, based on both research and experience, I recognized it was a time for a major innovation in training for new nurse practitioners who are committed to being primary care providers, and particularly in our safety net settings, like community health centers, like rural health centers. We were asking them to embrace the full scope of primary care practice from the start. But we saw firsthand what one new nurse practitioner called the shock and awe of seeing just how sick people can be in primary care and how complex the care was in our settings like community health centers. And while all new nurse practitioners are prepared and competent for entry-level practice, what we say is there are very few entry-level patients in our settings in community health centers and in rural health. And this gap between preparation and practice quickly gives rise to burnout, frustration, and too often we saw early departure by nurse practitioners from full-scope primary care roles and the practices that so need them. And so, in 2007, the Community Health Center developed and piloted the country's first formal postgraduate residency training program for new nurse practitioners. We did it with 4 new nurse practitioner residents, but with a commitment to building a model that others could replicate across the country. This intensive year-long training has given rise to a national movement. There are now 250 postgraduate NP residency and fellowship training programs specializing just in primary care in the United States, and many more in the specialty and acute care settings as well. Just in community health centers, there are now 75 programs. Some are joint nurse practitioner and PA programs. These programs are very carefully designed and structured to ensure intensive clinical training with expert preceptors, the development of mastery in caring for highly challenging conditions such as opioid use disorder, multi-chronic illness. But the training also includes the skills to improve practice as well as deliver care, to provide the most effective prevention and health promotion care, and the resilience to thrive as primary care providers and members of a high-performing team, which must, of course, include our medical assistants, our nurses, our community health workers, and our behavioral health clinicians. What started as a model has grown into a movement, and research indicates that nurse practitioner graduates of postgraduate training programs remain in primary care and underserved practices at higher rates compared to national averages. They are also more likely to mirror their patient populations. They are more diverse, and they serve more underserved populations. An initial concern that creating such programs implied that nurse practitioners were somehow lacking has given way to a recognition that this is simply what new nurse practitioners want and deserve, and 77% of newly graduated NPs report that they would like to do a postgraduate residency program if one were available. In 2019, HRSA's Bureau of Workforce funded 36 of these programs. That's only 36 of the 250 in the country. They required that they be accredited in order to assure rigor in their programs, rigor and quality, and we're happy to say the consortium of which I serve as chair is recognized by the Department of Education as an accrediting organization. I want to say that in my work with the consortium, I have had the pleasure of visiting NP residency programs across the country, from the state of Washington to Maine, from Hawaii to Alabama, and many points in between, including Indiana. I am deeply impressed by the commitment of the boards, the executive and clinical leaders, and the frontline clinicians and staff to this model because it works. It works in attracting those for whom the desire to serve and care for people as a primary care provider is both a profession and a calling. It works in retaining them in our most challenging practices as primary care providers and as future leaders in healthcare. But these programs need federal support to continue this work and for new programs to start. As I've said, HRSA has stepped up with a small program for 36, but we need more. Today, I've focused on the nurse practitioner as primary care provider, but I know firsthand we need to devote our attention to every member of the team. I'm so glad that Norma Quinones is speaking to you today about medical assistants. Thank you for your concern, for your commitment to our healthcare workforce, and to our people and communities that rely on us for this primary care. Thank you so much.
Thank you. Dr. Verret?
Chairman, thank you for having me today. Chairman Hickenlooper and members of the committee, thank you for the opportunity to address you today. Chairman Hickenlooper, members of the committee, thank you for the opportunity to testify today. My name is Verret, C. Verret. I serve as the sixth president of Xavier University of Louisiana. My institution is historically a Black university, or an HBCU. It's also a Catholic institution. The ultimate purpose of Xavier is to contribute to the promotion of a more just and humane society by preparing its students to assume roles of leadership and of service in a global society. I was asked to testify before the committee about how Xavier has employed innovative strategies to address critical underrepresentation of Blacks in health and other science, healthcare and other sciences. I will speak for my institution, but you may extend many of my comments to the other 100 accredited HBCUs across the nation. Xavier is renowned for its work as the leading institution in training African American undergraduates to go on to complete the MD across the nation, and also PhDs in the physical and life sciences. Our considerations when developing new programs, especially at the graduate and professional levels, include special criteria. 1, whether the programs reflect a growing demand. 2, will the degrees lead to positions with possibilities for personal growth and flexibility? Will degrees earn salaries that allow students to repay their loans? If the proposed degrees are of service to the larger society and especially underrepresented communities? And most importantly, whether these degrees offered at Xavier help diversify professions and increase representation. Our new programs target professions in which only 1 to 3.5% of practitioners identify as African Americans. Their diversity is critical to provide equitable healthcare outcomes. Xavier started this approach many years ago. However, the challenges of healthcare equity was highlighted in the recent disparities demonstrated by the COVID pandemic. Provide an overall perspective of what we do at Xavier. Since 2016, we have started 23 new programs. New undergraduate programs include bioinformatics, data science, medical laboratory science, neuroscience, robotics and mechatronic engineering, and statistics. At the graduate levels, programs include a Master's of Health Science, Physician Assistant Studies, Masters of Public Health and Health Equity, Speech and Language Pathology, MS in Pharmaceutical Sciences. 3 upcoming programs that are the MS in Health Informatics, and also MS in Genetic Counseling, and the Doctor of Physical Therapy. While we are proud of the work we do at Xavier, we and the nation are challenged to address the stagnant numbers of Black doctors and scientists nationally. Much more must be done to develop a representative community of healthcare providers and scientists positioned to reduce and eliminate health disparities. To fully address this need, the pipeline sending undergraduate students into schools such as Xavier must be vastly expanded. This will require providing pathways to all, but most importantly to our first-generation students, including information to families on pathways to college, the application financial aid processes, all to make the journey achievable without the burden of lifelong debt. America cannot afford to develop only a subset of its talent, forsaking many whose contributions are needed, losing them due to socioeconomic barriers. With this being said, I would like to firmly thank Congress for recent investments in funding to HBCUs, tribal colleges and universities, minority-serving institutions. I'm also grateful for funding which benefits our students' population directly. Lastly, may I make a few suggestions and recommendations? We need to double the Pell Grant. Embracing the only national program that helps low-income students achieve higher education would serve the nation and ease the path to needed professions. Revive subsidies for the first 2 years of education at HBCUs. Still, more than 50% of our students at HBCUs are first-generation learners. Removing financial impediments will expand the talent pool to the United States. Investing in an additional $5 billion to expand the Title III institutional grant programs for HBCUs will go a long way to strengthen our institutions. A few historically Black institutions produce a great percentage of the diversity in health and STEM. Acknowledge this work with more robust resources to expand their impact and capacity. Fully fund HCOP, the Health Careers Opportunities Program, and similar programs. Too few Black institutions have capacity and resources to function as major research institutions, what we speak of the R01 status, even though they are actively nearing that point. More federal investment developing and building capacity at a few HBCUs, Xavier included, will allow us to continue to expand our work in response to national need. In President Biden's Joint Families and Infrastructure Plan, HBCUs, tribal colleges, and MSIs were slated to receive $90 billion in investment in research-related infrastructures. This is needed and essential. Another point I would say is to forgive the balance of the HBCU Capital Finance Program debt for the remaining HBCUs which were excluded from that forgiveness. We at Xavier understand that this relief should not be routine. However, there are numerous opportunities in the Ignite HBCU Excellence Act, unburden these institutions, and including Xavier. Last but not least, we as a community of institutions are still processing the cowardly acts of terror which will have disrupted so many HBCUs. I anticipate representations at UNCF and other representatives of our universities will put forth funding and policy recommendations to appropriate committees in the coming weeks. I hope the members of this community will support these recommendations, mitigating threat and safeguarding our nation's most precious assets, which are our students. Mr. Chairman, I thank you. I look forward to answering the questions of the members of the committee.
Thank you. Ms. Quinones?
Good morning. What an honor for me to be here. My name is Norma Quinones, and I'm the Nursing Services Manager at Clinica Family Health, a community health center in Lafayette, Colorado, that serves low-income individuals. I applied to Clinica Family Health as a medical assistant in 1992, when our organization just had one clinic with 6 exam rooms and about 25 employees. I've been able to grow with Clinica over the past 30 years and will never forget being given the opportunity to start my career as an MA. Within Clinica support, I became an LPN and worked as a nurse team manager for several years. I am now the nursing services manager for Clinica. I love what I do. I get to dedicate my time to staff and students as they deliver medical, dental, mental health care to thousands of patients. Part of my job is helping coordinate the NEMA program at Clinica, which means I get to support future MAs on their own educational journey. The National Institute for Medical Assistant Advancement is unique, nationally accredited, non-for-profit post-secondary program formed in 2016 by 2 leading FQHCs, Salute Family Health Center in Fort Lupton, Colorado, and Community Health Center, Inc. in Middleton, Connecticut. NEMA is a model for addressing primary care health workforce shortages, creating an accessible entry point for long-term healthcare careers, and diversifying the U.S. workforce. Before working with NEMA, we had trouble finding qualified medical assistants prepared to work in our demanding environment. Some who graduated from expensive programs incurred a lot of debt, making it hard for them to resist higher-paying jobs in the for-profit sector. It was hard to find good MAs and harder to keep them. NEMA's program has helped us build a workforce pipeline within our community and reflective of our community. It provides an affordable option that allows students to work part-time while they're completing the program. It prepares graduates well for demanding primary care settings where MAs are desperately needed. It is true grow your own model that provides opportunity for non-traditional students, single parents, recent immigrants, first-generation high school graduates, or those of us that enter the workforce at an elder age. Nationally, 90% of medical assistants are female, and the majority are Black, Indigenous, or people of color. NEMA's program allows us to help participants begin a healthcare career that would otherwise be out of reach for them and earn a livable wage. Over the past 3 years, Clinica has hosted 18 NEMA externs. We hired 15 of those 18 upon graduation, and most are still with our organization. This is a valuable workforce pipeline for Clinica, and it is extremely rewarding to watch the students grow in their careers as I did. MAs can enjoy a rewarding career whether they stay in the MA role or move to management, nursing, administration, or other roles. For example, one of the early NEMA graduates is applying to become a nurse team manager, a medical assistant team manager. NEMA is an excellent program with student retention of 89%, a graduation rate at 84%, a national credentialing exam pass rate of 89%, and a verified job placement at 81%. NEMA's program has already graduated more than 250 students, and it's growing rapidly. NEMA has 48 active clinical partners across 14 states, including community health centers, hospital systems, and other safety net providers. This successful program could be scaled to reach thousands more students each year and to help address critical workforce shortages in diverse urban and rural communities across the country. Thank you for the opportunity to share Clinica and our students' perspective on NEMA, what it has meant for Clinica, and how it can serve as a model for healthcare pipeline and pathways efforts.
Thank you. Ms. Gressler?
Good morning, and thank you for the opportunity to testify today. As an economist who focuses on labor policy, I would like to first discuss the current labor force shortage across the U.S. and then look specifically within the healthcare sector. The current labor shortage is unlike any before in U.S. history. We have an employment gap of at least 4 to 5 million workers. Job openings, which are currently at 10.9 million, are 40% above their pre-pandemic record, and they are more than double the prior 10-year average. And employers are struggling, as 49% of businesses have positions that they're unable to fill. Nearly half of all businesses have increased compensation in December alone, and 32% plan to increase it over the next 3 months. Those higher wages are a great thing when they come from workers becoming more productive, but when it's simply employers having to pay people more to do the exact same thing, that translates into higher prices. And we've seen today with a 40-year record high inflation that those wage gains have been entirely erased and real wages are actually down. Resignations are also at record highs, with nearly 1 in 3 workers quitting their jobs in 2021. Replacing workers is extremely costly, and this adds to burdens and creates higher costs. COVID-19 is not the main cause of the labor crisis, but rather bad policies that have restricted the labor supply, and $6.6 trillion in deficit finance spending has artificially increased demand for goods and services. Instead of spending more federal money and imposing more labor market distortions, policymakers should remove the employment barriers that they've created. That includes eliminating welfare without work policies, reducing tax burdens that are prohibiting higher wage and productivity gains, letting people pursue the work that they want, and expanding childcare options by allowing parents to use federal Head Start funding dollars at a provider of their choice. The healthcare workforce shortage includes both longstanding issues as well as pandemic-related ones. So prior to the pandemic, healthcare employment had been growing faster than overall employment, but that has since reversed, and especially so since the implementation of COVID-19 vaccine mandates. If healthcare employment had grown at the same rate as total employment over just the past 3 months, we would have 73,000 more healthcare workers today. It's one thing if we're frustrated by long waits at restaurants. It's certainly a major disruption to have canceled flights or school buses that don't show up. But when hospital units close or people have delays in surgeries and simply can't access health care, that significantly impacts people's health and even their lives. The CMS vaccine mandate could remove 70,000 or more healthcare workers from their jobs. Congress should prevent this by protecting medical providers' rights to set their own vaccine policies. The longer-term healthcare workforce is primarily a state issue. State governments need to eliminate unnecessary licensure, scope of practice, and certificate of need laws that limit the healthcare workforce. Doctors and nurses should be able to practice their professions where the need is greatest and not simply within the geographic confines of their license. It's particularly ludicrous when a provider can't have a telehealth visit with a regular patient simply because they're out of the state at that time. Also, needlessly restricting nurse practitioners from performing services that they were trained to provide limits care and drives up costs. And certificate of need laws have consistently proven anti-competitive and harmful. While states are the primary gatekeepers of the healthcare workforce, the federal government can remove unnecessary burdens and promote competition and flexibility to better meet America's healthcare needs. Some specific actions include adjusting federal to state healthcare payments to shift the burden of bad policies like certificate of need laws onto the states that impose them, expanding the use of telemedicine, improving the graduate medical education system to meet more communities' needs, not shortchanging home healthcare workers by sending part of their paychecks to unions without their consent, and reducing the regulatory burdens required by federal healthcare programs. The time that's spent on paperwork and regulatory compliance is time that's not spent treating patients. 58% of doctors list paperwork and regulatory burdens as their biggest complaints, and nearly half of all physicians say that they are considering retiring earlier than planned because of changes in the healthcare system. Lives are literally at stake because of the healthcare workforce shortage, and many regulations are needlessly making this worse. Congress should immediately stipulate that vaccine mandates are decisions for healthcare providers, and state and federal policymakers should reduce barriers and burdens to better respond to Americans' increasing healthcare needs. Thank you.
Great. Thank you very much. Thank all of you. I look forward to beginning the question. And before we get to that, I would like to turn the microphone over to the chair of the overall Health Committee. This is the Subcommittee on Employment and Workplace Safety, but Chair Murray is here, so I'd like her opening statement.
Thank you very much, Senator Hickenlooper, for organizing this hearing to talk about how we can support our healthcare workforce. And thank you to all of our witnesses for offering your insights on this really important topic. The discussion about how we can diversify our healthcare workforce is so important to improving healthcare for communities of color and increasing health equity. I'm really glad to be able to join for a few minutes today and really highlight the challenges I've been hearing about from healthcare workers in particular, something I know is a big priority for all of us. I have heard from so many nurses and doctors and other healthcare workers back in Washington State about how hard this pandemic has been, and I know there are similar stories across the country. Healthcare workers have handled long hours, overcrowded facilities, fighting a deadly new virus, often while receiving low pay. They've worried about whether they have the equipment they need, or whether they're safe at work, or would get sick or bring a deadly virus home to their family, and whether they could make ends meet on the wages they were paid, let alone if they had to stay home to care for themselves or for a loved one. They've had to patiently deal and compassionately deal with patients and family members who may have been afraid they may never see their loved one again, frustrated by steps required to keep everyone safe, or even skeptical about the threat of this virus due to misinformation, and angry with healthcare professionals who are just trying to help. They've seen the pain of this pandemic up close and personal, and it's taken a real toll. Far too many healthcare workers have been killed by this virus, and many more are dealing with the trauma, mental health challenges, and burnout in its wake. That's why I pushed for historic investments in the American Rescue Plan to further support our healthcare workforce, including robust funding for workplace safety and health protections from COVID-19, as well as address some of the personal challenges facing these workers. This pandemic has really made it clearer than ever how important it is that our healthcare workers are paid what they deserve, that they have a voice in the decisions about how we should recruit and train and retain healthcare workers, have safe workplaces which are adequately stocked and staffed, and are protected from infectious diseases and workplace violence. We also need to make sure that all workers have paid leave for when they need to care for themselves and their own families, so they can get mental health care when they need it and can choose to join a union and collectively bargain for better wages and working conditions. After all they have done for our communities, we owe it to our healthcare workers and everyone on the front lines of this pandemic to listen to their experiences and respond to the challenges they are dealing with. As we work to improve recruiting, retaining, and training for healthcare workers, one critical aspect of this is ensuring we improve the working conditions. So I'm glad we're having this discussion today on ways we can support our healthcare workforce, and I'm committed to making sure we include healthcare workers in this important conversation as it continues. And before I finish, I'd just like to note I will have letters I plan to submit for the record and ask consent to do so.
Without objection.
Thank you, Mr. Chairman.
Terrific. Thank you very much. All right, now we'll start our questioning. My only guidance, I usually instruct witnesses to keep your answers concise, because I think you will be amazed how many questions we have, and we'll get to more questions if we can be concise. I realize I always hold out 45 seconds or 30 to 45 seconds as a goal. I realize that's usually not always possible. Let me start with Dr. Verret. Your university's led the way in producing students and alumni who excel in various health professions, in particular the Xavier's focus on intensive faculty advising, academic resource centers, and co-curricular programs appears to have been critical to the success exhibited by achieved by your students. I mean, this is clearly a successful model. Xavier has been consistently for a number of years the #1 university and as a source for African American students who go on to become doctors. Now, you described certain additional investments that the federal government could make. How else at the federal level can we replicate? I mean, really try to take the success that you've achieved with Xavier's programs and replicate it at schools across the country.
Well, I would say that to begin first is that clearly what we do in the pipelines before the pre-collegiate experience is an important piece. I would add that because in preparing students who may not be aware of the access, the opportunities themselves, because in many cases they have not the only hearing of college towards the end of their high school years is a crucial piece in getting that talent pipeline. The other piece is that we also, it is important that we help students discover their weaknesses because all students come with weaknesses early in their education, so that what we do in providing academic support is first in the discovery process where students discover what they know, where they are strong and where they are weak, and what support they would need. The other piece that's a difficult one to replicate easily is actually the intentionality of forming a faculty that is committed to that kind of work, and how the faculty is committed to actually recognizing that not all students come with the education that they fully deserve. Most children do not choose the schools that they attend, at least not yet in this country. And so students come with different deficits. And the important thing is that that deficit does not mean a lack of talent, ability. It's important that we remedy those deficits early in the experience, not later. It's important because what we discover in the first or second year, we can repair. In the third or fourth year, it's more difficult. So it's important that we confront that. And I use an expression of one of our students in understanding that even though they may complain of the faculty, of the staff, or other things at Xavier, they will say that the faculty has our back, because they know that commitment. And that faculty committed is an important element.
Excellent. And I just learned last week that the College Board now is not just AP, advanced placement tests that they give. There are enough high schools all across the country recognizing the need for healthcare professionals that they're going to have an AC test. So kids in high school it'll be an advanced career opportunity and allow them to get some recognition and credit for taking these early during high school preparations for a healthcare career. Dr. Flinter, during the COVID-19 pandemic, obviously burnout reached an apex. Millions of workers are reevaluating what they value in their job or their career. I mean, even before the pandemic, burnout in the healthcare workers was a major challenge given the nature of the work, the intensity. Dr. Flinter, how can upskilling opportunities like nurse practitioner training programs help reduce the burnout and address long-term retention among the healthcare workers?
Well, thank you for the question. And let me say it was our honor to serve in the COVID pandemic. I think in my organization, we often felt like we were on the front lines of a battle unlike anything we'd ever seen. And whether we were outside in the freezing cold or the burning heat of July, people were very grateful to serve and to make a contribution through first testing and then vaccine. But the work is very difficult inherently. People sign up for the difficult work of healthcare, right? To meet humanity sometimes at its most vulnerable moments and to also work to keep them well. If in addition to that, you don't have the skills to provide the level of care that is needed by the population you care for, and again, I speak to our safety net settings in our rural areas where primary care is where everybody comes. They don't go off to a specialist on the first pass. You significantly increase that difficulty. If you don't have behavioral health clinicians as part of your primary care team, you significantly increase that difficulty. If you don't have the MAs who can help manage and make automatic what should be automatic in prevention and screening, you increase the difficulties. So training is a big piece of it. Making sure that we have the whole team and not just part of the team to have the most effective primary care, I think, is another piece. And then the third, of course, is it's every organization's responsibility to ensure that they're providing both the safe workforce, as Senator Murray alluded, but also providing the ongoing training. We participate in the NEMA program. We welcome students, more than 200 a year, from all the disciplines and all the healthcare institutions in Connecticut to make sure that we're building that pipeline that can continue to increase that skill level.
Great. Thank you very much. And I have more questions, and hopefully we'll have time for a second round. If not, I'll make sure I submit them in writing. Now I'll turn it over to Senator Braun for his questions.
Thank you, Mr. Chairman. Touched on it earlier in my opening statement that I feel a lot of what we're navigating through currently, addressing COVID, it was a feisty foe. None of us knew much about it. I know in my own company, which in discussing what we were going to do when I touch base weekly, it was about treating it with respect. It was about doing those things that we all know now that the science is saying what did work and what didn't work. And so often you get the political science involved in the discussion, and it keeps us off the mark. I was going to ask Ms. Gressler about vaccine mandates. I led the charge in the Senate with the Congressional Review Act about why that didn't make sense. Life is not fixed ever from the top down. It'd be different if we were knocking it out of the park here at the federal level. And in my 3 years, I have so many people come here wanting more of it, heard some from the panel that we need to spend more money. The reality check is we borrow almost 25% of everything that we spend here. And that's up close to 30%. It's a bad business plan to probably look for more of that. I agree, on the other hand, that these are real issues. But do we keep shoveling more into a broken system, or do we take a more entrepreneurial, a different approach? The results say do something different. It's 20% of our GDP, it's 10% elsewhere. Ms. Gressler, you told me what you think about vaccine mandates. That was going to be my first question. Being an economist, my degree was in economics. After I thought I was going to be a biology major, and when I found out it took 9 years to become a surgeon, I didn't get into the field. That's part of the issue too, how long it takes, how costly it is for practitioners, for doctors, on the firing line. How much of what we struggle with is due to the fact that I'm one of a lonely voice of Republicans that says the industry itself, no competition, no transparency. It's a business of remediation, not prevention. Increasingly dominated by large corporations that do not want to do the things that before you start throwing more federal dollars at it, how do you fix the system itself? Is the healthcare industry broken in the fact that it doesn't embrace competition, transparency, all kinds of barriers to entry, not to mention that we have a healthcare consumer that really isn't interested in her or his own well-being other than fix it when it's broke?
Yeah, let me start there with the immediate, and you mentioned the vaccine mandates, and that's where I think that you know what it is like as an employer. The medical facilities that are out there know the needs of their communities, they know the needs of their workers, and they're the ones that are better able to make the decision to balance the safety needs and the needs of actually having people there to treat their patients that come in. And so that's why the decisions need to be made there. And we have seen in places that have implemented these mandates having to lay off up to 2% of their workforce. That's an enormous number if you multiply that across potentially 14 million workers. And the particular problem is for more rural areas. I know a lot of you are from rural areas, and those are smaller facilities. And if they lose 2% of their workforce, that's really difficult for them. And I know I had a family member myself that had a pediatric emergency and was told, you need to travel to another state 160 miles away to that hospital because the nearby children's hospital is having shortage because of the vaccine mandates. And so that's an immediate problem. But there are many long-standing issues here. Ultimately, the states are the gatekeepers of who gets to practice medicine within their state. And so a lot of it comes down to that. And certainly it doesn't make sense to be throwing federal money at a gate that's not going to be opened up. We have seen more than $10 billion invested recently. I think it will take time for that money to play out. You can't increase the workforce overnight, and so we need to wait and see what happens there. But there are also things immediately that don't even cost any money just removing those regulatory burdens that are out there. Part of the burnout issue is you want to have more time.
Ms.
at home.
Gressler, before we run out of time, and I'll come back and ask it again, removing regulations, all of that, what about the industry itself? You're an economist. Does it embrace competition, transparency, and does it have barriers to entry? Give me your quick kind of pass on that, and if I need more, I'll ask it on a second round.
Yes, there are absolutely barriers to entry out there, and there are interests that are, fighting against the competition that could lower costs and that could improve the quality of care. And part of that has to do with, I would say, an excessive level of federal money and federal rules and regulations that kind of dictate the system.
Thank you.
Thank you. All right, Senator Baldwin.
Thank you, Chair Hickenlooper. I thank you, panelists, for your testimony today. I really appreciate your focus on this critical issue. Certainly, what you've been discussing is apparent in the state of Wisconsin in my discussions with healthcare leaders and advocacy groups for the health professions. One thing I want to hear thoughts about is in terms of preparation, especially in nursing. We have an urgent nursing shortage in the state of Wisconsin, in hospital settings, in clinical settings, in nursing home settings. Although at the same time, there are eligible students who are turned away from potential training because of the shortage of nursing faculty. And the aging of that workforce only suggests it's going to get worse rather than better. I wonder if Dr. Flinter and Dr. Verret, if you could both speak to those issues as you see them.
Excuse me. Thank you for the question, and I think it's multifactorial, right, in terms of the issues. Certainly the aging of the nursing workforce, including faculty, may be one, but it's also a compression often in clinical training sites. That's part of why I think nationally community health centers have really tried to step forward and say, remember, training in primary care is very critical for RNs as well, and really step forward to welcome more students. And that's one way we contribute in that setting to it. Beyond that, we need to recognize that nursing is a broad profession and that people may find their place where they can make the greatest contribution as faculty people. They may find it in private settings. They may find it in our safety net settings, and to support people in having opportunities for really good preparation for those roles at the graduate level as well as at the entry practice level. We've just initiated a program with universities in Connecticut to make sure that their fourth-year students actually have a capstone experience in a high-performing community health center to remind them that that's an option as well. And we need to emphasize all of those pathways: research, practice, education.
I would just want to add that also we have, as Dr. Flinton mentioned, there are many factors. The shortage, the number of nursing programs, faculty, and all that drives the issue. But also the other factor is also the pipeline of students. That we have the number of barriers to students, especially our students who are of modest means, who are making decisions based upon, can I afford it? Can my family afford it? What is the impact? And how we actually create pathways where the barriers are not as high to actually access those fields, because there's a lot of talent in our second, third, fourth, and fifth grades. But I don't think we avail ourselves of all the talent that we have at the table as a nation.
Yeah. We've been talking a lot about primary care, but the complexity, Dr. Flinter, of primary care, it doesn't suggest necessarily a healthy population, et cetera. I have been focusing in on some of the urgent shortage issues, whether it's the infectious disease area of practice, or the palliative and hospice care workforce, or the perinatal workforce. I wonder if you can talk about why it's important to fully build out the workforce and training pipeline when we think about shortages in these areas. And then Dr. Verret, if you can speak to particularly the necessity for diverse workforce in all of these areas, but I think so strongly about the perinatal workforce. I'm involved in the Perinatal Workforce Act because even before the pandemic, Black women in Wisconsin faced significantly higher rates of maternal complications and deaths than white women. And the Perinatal Workforce Act, which I sponsor with my colleague, Congresswoman Gwen Moore, to improve access to maternity care and grow diversity of the perinatal workforce. This is critical to addressing some of the staggering maternal health inequities that we face as a country. So if you could start, Dr. Flinter.
I will, and I want to thank you for your comments about the critical issue of maternal infant morbidity and mortality. And I want to tell you that is front and center, I think, of all of our efforts wherever we are. You know, when it comes to the specialties and the pipeline, every specialty is critical. And, you know, you speak to your passion. I'm speaking to primary care today. But we could not do what we do without those specialties when the time comes. I think the most effective thing we can do in primary care is to make sure that we are practicing to the maximum competence that we can within primary care and then sending on the people that really need that specialist. And if I may, one innovation that has been proven to reduce costs overall and to increase access and improve outcomes is something called an e-consult. You know, we used to, in safety net settings in particular, you would wait months to get an appointment with an endocrinologist, with an ologist of just about any kind. We developed a model we call e-consults now through a group called ConfirMed, where we can get, a primary care provider can get an excellent in-depth consultation within 2 days and decide. And then it turns out about 75% of the time, they don't need to follow up in person. They can give guidance to the primary care provider. That means there's room in that specialist practice to see the people who really need to be seen. And I think that is absolutely critical. I know others than me decide what those numbers are, how many in each specialty. We need the right care from the right people at the right time. And I think that's part of avoiding the kind of excess cost that people talk about. You need to see the right person at the right time. HIV used to be a disease of specialists. We train all of our primary care providers to be HIV specialists, just as an example.
Well, what I would add to the diversity question, why diversity? I would first begin by that it is an essential element of trust in the healthcare system that's a barrier. It's not so much about having your physician. It's not so much about having your physician as the someone of the same sex, race, ethnicity as you are. But the presence within the healthcare system of people who resemble you creates trust in the system. That's one social factor. And as we mentioned in medicine very often, the social factors are as important as the technical and clinical factors as well. The other piece about that I would say is that we have to actually understand that our most precious resource as a nation, as any nation, are our children and the brains that they have. And that we have, in the last 100 years, that we have depended upon assuming that we could rely upon only a fraction of the resource of our population for talent. And we do know that there is genius that is available to us, whether it is in architecture, construction, in medicine, or in science, or wherever. That by not educating students who actually can become and aspire to join us in many of the professions we need, teaching, nursing, medicine, wherever we are driving this workforce shortage that we have, the talent need, and I would even elevate it to a higher question that if the U.S., like any nation, aspires to lead internationally, globally, on any dimensions, as economically, from a geopolitical point of view, it needs to have the brains that it needs to cultivate its own brains. And that begins in K through 12, and we have to funnel them through whatever level of education allows for them to refine those skills. And that's where we're seeing in healthcare that we need that presence, but we need those numbers. Those numbers are scary because as you and I are all getting old, we will need care. And that care may not be there.
Thank you. Now I'll turn it over to Senator Tuberville.
Thank you, Mr. Chair. Thank you very much. Thanks for being here. I continue to hear from hospitals in my home state of Alabama that our nursing shortage has reached a state of emergency. We have so few nurses to go around that hospitals have resorted to contracting with nurse staffing agencies to fill empty slots. These agencies pair nurses who are willing to travel with hospitals facing large vacancies, and in many cases, they fill a very important need. I'm concerned, however, that these agencies might be taking advantage of a very dangerous situation. They're able to charge a high percentage cut for their services, and hospitals have no choice but to pay their prices. It's huge in our state of Alabama. And I want to be clear, nurses are the backbone of our healthcare system, and they have been on the frontline heroes, our frontline heroes throughout the COVID-19 pandemic. Every nurse should have the right to take the highest salary available. I do not want my question to be interpreted as undervaluing nurses' worth in our healthcare system. But I am concerned, however, that these staffing agencies might be exploiting our already overwhelmed healthcare system. And I'd like for all four of you to say something about this just briefly. This question is for everybody. And, what do we currently know about these agencies and the cut they get from our lucrative contracts with struggling hospitals, and what can be done to address this issue?
I'll start. I don't know a lot about the agencies themselves, but the fact that so many are going to those agencies and needing that. And two things there is just the burdens that are placed on the nurses, and those burdens were increased because of COVID-19, and some of them were necessary, some of them weren't, and a lot of underlying things before then weren't. And so how can we reduce the amount of time that nurses and that doctors need to spend on needless paperwork and regulatory burdens so that they can have more time to be treating patients? That effectively gives you more workers because it's more worker time. And then also just addressing the state laws so that the demand can go where it is needed most, and we don't have those barriers that are needlessly preventing people from practicing where they should be.
Thank you.
I am sorry, I don't know enough about nursing. That's out of my scope where I work, so I have no comment.
Thank you.
I too don't know much about the agencies, but I'm aware of that. We have effectively a shortage of nurses, and so there's a supply issue, but also clearly it's becoming a compensation issue for many of our hospitals as well. How we compensate them will be an issue, but clearly that problem has to do with basically a shortage of nurses, that hospitals are competing among themselves for nurses, even within the same city.
Thank you.
Thank you, Senator. And may I say, I just had a chance to visit Cahaba Medical Care in Alabama and a nurse practitioner residency program there. You all are doing a great job down there and meeting the needs of your rural population. The travel agencies have always been with us, I think, for decades. So this is not new. I think they fulfill a certain role most of the time. There's a portion of people who like that lifestyle. Wouldn't work for me as a nurse, but they like the lifestyle of traveling to different organizations. And they play probably a vital role when, not in COVID times in the same way, when there is a shortage of people in one area or another of a hospital. Where we have an issue, where I have an issue, is when we are losing valuable experienced nurses from positions because that position is no longer tenable. And often that position is no longer tenable because it's been understaffed for a long time or under-resourced, and people are just frustrated. I think the issue is to support our host organizations in making the environment for nursing practice, whether that is thinking about the patient workload so you can give safe care, the other people on team, to make that organization a place that nurses want to commit to and stay. I don't think people lightly give up a satisfying practice as a nurse to do travel nursing. But I think the travel agencies also play some role on an ongoing basis. Again, COVID threw everything to the wind. State policy, I think, can sometimes aggravate or help this. And I will say my state of Connecticut took broad action to credential a whole group of people as what they called Tier 2 vaccinators during the COVID pandemic in order to not have to rely only on nurses or physicians, PAs, to give vaccines. And our dentists, our dental hygienists, podiatrists were able to come and get trained and get an additional certification. So we need to, I think, always look at these things from a variety of perspectives, but the core is to make practice satisfying where nurses are in their communities, I think.
Thank you very much. Thank you.
That's an instructive row of answers to a good question. Now and I'm sure you're aware, I should have said this earlier, we do have, this is a virtual hearing, it's a bilateral hearing. So we have now Senator Rosen from Nevada on virtual, so she's next.
Well, thank you, Chair Hickenlooper, and of course, Ranking Member Braun for holding this really important hearing today, and of course for the witnesses for everything that you do and for being here with us. And of course, it's so important that we lower those barriers for providers. We all know that because healthcare providers with advanced training, such as physicians, like you mentioned, dentists, they have to complete residency trainings in order to care for patients. They often exit the training with significant student loan debt. The debt is made far worse by the fact that interest accrues while they're still in residency training. They're not actually in full practice. And that creates additional financial barriers for providers otherwise interested in serving patients in rural areas or underserved areas, of course, all across this country. All 17 counties in Nevada, unfortunately, are designated as health professional shortage areas. And our health outcomes are especially likely to be worse among rural and minority residents than those in more urban centers. So in order to improve health outcomes, to address our nation's doctor shortage, we have to do more, not only to encourage providers to serve in rural and underserved communities, but also to reduce those existing barriers. And it's why I'm working on bipartisan legislation with Senator Boozman that would allow medical and dental residents interest-free deferment on their student loans while serving medical dental internship or residency programs. And so Dr. Flinter is someone who founded America's first nurse practitioner residency program. How could pausing student loan interest accruing during residency help provide flexibility for providers who will opt to serve patients in rural and underserved areas? And what other incentives do you think the federal government should be looking at to make it easier for us to get the really good quality health care we need all across this nation?
Well, thank you for that question. And I will tell you that facing that mountain of debt as you're coming into your residency program, those mandatory payments, is a daunting challenge for providers who are still in their training phase. I think that what you've proposed, Senator Rosen, pausing student loan interest accrual during residency is what I would call a very pragmatic, reasonable thing that probably makes a big difference for people. I think the issue is that debt influences people's choice of where they're going to practice, as you have used the example of the state of Nevada. So I think that's a very pragmatic and useful idea. I want to point out that that's part of a constellation of strategies that we have here in the United States that all could be expanded to make it easier for people to tackle the training and then to choose the practice setting based on where they want to serve and where their passion is. I will tell you that, when I was an undergraduate student earning my bachelor's degree in nursing a long time ago, I worked off my student loans through a federal loan repayment program as a rural public health nurse. When I chose to go back to school, to the Yale School of Nursing, and become a nurse practitioner, I was fortunate enough to be taken into the National Health Service Corps, which had an obligated period of service afterwards. They sent me to what was then a small community health center that Senator Hickenlooper knows on Main Street in Middletown. And, I think 47 years of practice is a pretty good return on the federal government's investment in those loans. And this is what we see in my own organization. There are many people with decades of experience who started in community health service in underserved areas because they had help from something like federal loan repayment or the National Health Service Corps. So this would be one more tool, I think, in the toolkit to help people.
Well, that's great, because I want to build on exactly this, because we not only have this area just in overall physicians, dentists, nurse practitioners, and the like. We have, especially in my state, shortage of certain medical specialties. And so we have our urban, our underserved communities, and particularly our rural, our far-flung frontier communities. They have to go without specialty care at all. And so I'm currently working on some legislation to create a loan forgiveness program for specialists who care for patients in rural areas. And so can you speak about maybe the challenges that primary care providers have in trying to bring specialists either in person, maybe even virtually through telehealth? We have to have people to refer them to. And what do you think we can do to help with that? Again, I'm just building on what you said before, please.
Great. Well, thank you. And I think a few moments ago, I addressed the issue of what we can do with e-consult access from primary care to specialists. So that which can be done by primary care, often in consultation with a specialist, though not the specialist necessarily directly seeing the patient, is a very important piece of that. And we've done the research on that. It is clear that's now becoming a national best practice. So the people seeing the specialist are the people who really need to see the specialist, and others can be done in management between specialists and primary care providers. Telehealth has certainly been a huge benefit to us, I think we would say. You know, it certainly is true in rural areas, but even in urban areas, I think we've all seen how difficult it can be to connect primary care providers and specialists, and how much additional double work you can eliminate if you can connect with people virtually as opposed to in person. But beyond that, we need the training programs. We need the training programs for our specialists. They should have experience in caring for people in rural and underserved communities and for caring for all populations. One of the things that we know about training, and I think Dr. Verret would agree with me, that where you train has an awful lot to do with where you practice. If you can even have a part of your training experience in a rural area in underserved communities with underserved populations, there is a much greater chance, I think we call it imprinting, in you continuing to care for that population and remaining in that area. So like everything we are talking about today, there's not one strategy that is an answer. There are multiple strategies, and we need to embrace all of them. Technically, in terms of training, in terms of financial support for trainees, and in making sure that we get the right people to the right kind of provider at the right time.
Well, I couldn't agree more. Addressing the medical workforce shortage across the spectrum, having a good, strong broadband base to potentiate care through telehealth and qualified professionals all along the way. All of it makes a difference. All of it matters. And I'm trying to work on getting us all there. So I appreciate you all for being here today. Thank you, Mr. Chair. I see my time is up.
Thank you.
Thank you, Senator Rosen. Senator Cassidy?
Yeah, Dr. Flinter, you call it imprinting. I called it marrying a local.
That works too, I guess.
If it's a man, it's my observation that men live where either Uncle Sam or their wife tells them to, and so that's mine. I rarely start off with a personal anecdote, but I am today, because it's something that's so powerful in my experience in my professional life. As many of you may know, I'm a physician who worked in a public hospital for the uninsured for over 25 years, or about 25 years. And there's a woman who happened to be African American. Her nickname was Olive. She started off as an LPN, or maybe even a medical assistant. Went back to school, single mom, went back to school part-time, became, say, the LPN. Went back to school and continued her education and became an RN. Kept going back to school and then got her master's in nursing. Great. And when the nurse supervisor of the clinic retired, Olive took her place. Yes. Now, one, it's a great success story. For her personally, but it demonstrates to her children and a community the power of education.
Yes.
Aside from giving us a crackerjack nursing supervisor. And so, although I've not seen Olive since our hospital was literally blown up, that's the kind of facility it was, you just discarded it. She did an incredible job taking care of patients who otherwise would not have received such good care. So that said, I am heartily in favor of creating this opportunity for folks who perhaps would be the first in their family, first generation in their family to go to school.
Absolutely.
But there's other issues. Dr. Verret, I'm the author of the John Lewis National Institute for Minority Health Research and Endowment Revitalization Act that would revitalize the Research Endowment Program, or the REP, at the National Institute on Minority Health and Health Disparities. The REP was established to assist minority-serving institutions with low endowments to develop institutional capacity to successfully compete for NIH funding with their well-endowed non-minority school counterparts. Now, Xavier College of Pharmacy has been a beneficiary of this program. Can you talk about the challenges that universities like Xavier face in trying to be more competitive for federal research dollars, and why revitalizing this program would be important to Xavier, to others, and to our nation?
Well, that endowment program, I think, which was paused some years ago as for schools like Xavier, is the resource by which we build and develop bring the quality of faculty that our students need to encounter, but also facilities and other, in order to be competitive as research. And
So the facilities are as important as the faculty.
as important as the faculty, because one needs laboratories, one needs the equipment. For example, as was mentioned, putting a testing facility for HIV means that you have to have the thermocyclers. But that the equipment and also and the faculty, so that faculty, for example, who are researchers in a variety of areas, have to be able to set up laboratories or their computer systems for the work they do. So that one needs to be able to compete and place those faculty with those students. And also understanding that the research that we do at schools like Xavier is not separate from the instructional program. Our students enter as researchers with faculty in their research programs early as undergraduates in their second year. Likewise, it is about doing the practicing of the discipline. Our students do not only learn as biologists or learn as chemists, they do chemistry the same way they do history, the way our musicians do music as well. So that research, because that is the difference between the higher ed and what I would call secondary school.
And I think it's safe to say the role model of somebody who is successfully doing research can inspire. I have a professor that inspired me to become a hepatologist, a liver specialist, because of a couple of them. But between the two of them, they were so remarkable, I wanted to be like them.
One becomes a junior colleague
Yes.
as a researcher. And so that experience, and also it readies them for whether they go into professional school or whether they go into a PhD program. It's amazing the number of these students who actually fall into the MD PhD track. Mm-hmm. Also, our pharmacist students also who are pharmacists who are not only going into the retail sector as was traditional for many pharmacists, who are also who are taking the higher status of the PharmD and becoming part of the clinical sector or managing the therapeutics or the chemotherapy programs in some hospitals. So they've been taught to practice at the highest level of their license.
Yes, and of course, being a springboard, I mentioned to you earlier a family friend, but Dr. Holden originally went to Xavier Pharmacy School from Missouri, but that was when educational opportunity was not available for African Americans. And after going to Xavier Pharmacy School, went to DO school in California and practiced in California, a large pediatric practice in South Central LA, and changed a lot of lives that way. Thank you for your mission. I yield.
Thank you. It's a needed program.
Thank you, Senator Cassidy. I think we have time to, we're going to, Senator Braun's going to be back in a second to do let's call it a lightning round. No, I guess that's inappropriate. But I think we do have a few more questions. Ms. Quinones, I was going to ask the projections we've been hearing from everybody about the critical need to start growing our healthcare workforce yesterday. Obviously, the key there is to do it now, and we need to make it easier for those who don't have any experience to break into the field instead of creating barriers and making it impossible to expand the workforce. And we've heard a variety of people mention that over this last hour and a half. So you have unique experience because you came in as an entry-level assistant at Clinica to kind of begin your career in nursing. What were some of your experiences, and what are some things you think might be applicable, could be useful to other institutions, other healthcare providers that are looking to expand their workforce and become a conduit for people coming into the profession?
Yes, thank you for the question. So one of the unique situations at Clinica is that I recruit within our organization because, number one, somebody already has made the decision that this employee is a fit for Clinica. And the other thing that we focus on is development and growth within our system. And so we recruit within Clinica, go through the process of the NEMA program, and I facilitate and coach them and how do I want to say it, a connection between Clinica and NEMA. And so this is the way that we really grow our own. They're already in the system. They know our culture. They know our mission. And so we've found out, through other conversation is that this model really works for us because the commitment is already there from our staff. They go through the training, and upon graduation, they're already trained, I would say greater than 85%. So as soon as they graduate, they pass their MA exam, they're ready to start working as soon as they complete the 8-month program through NEMA. And so that's a huge benefit for our MA staff and nursing staff as well, because one thing that we encourage at Clinica is to work at the top of your license. And so this is a way that the medical assistants that have been working with Clinica for a while can support providers, nurses, and continue on.
Interesting. Dr. Verret, you mentioned a little bit about the reaching out to high school students and the Summer Science Academy, the Xavier Summer Science Academy.
Yes, we
500 kids to participate in. It sounds like a cross section of sciences, biology and math and
Chemistry.
STEM. Mm-hmm. Let's call it STEM. How do you reach out to find those students in the high school network? Are they all from within Louisiana, or are they from around the country?
The majority are from within Louisiana, but some come from around the country, a significant number, because the Store and Star program have a long history. The graduates of the program, to a high number, go on to college. Many of them do not go to Xavier, but they go to other colleges. To us, that's a success. It's what I call our external mission. Funding that has been a challenge because we fund that on dollars that we have or from foundation dollars when we can, but because those are not accessible through any funding program that we normally have. That is one pipeline of getting students early in their education to consider the science and to be exposed to that. We also what we also do is even weekend academies. For example, the robotics academy that is done, work that is done on weekends, is one way of capturing the imagination of young people. I like to make the point that if you remember that for science and health, it's not unlike music that students discover their passions very early in life, before high school. There are no musicians who decide to become great musicians at the age of 18 or 19. I think the same for scientists and also clinicians as well. So catching them even in before high school is fundamental, so that it's about getting that imagination and seeing that I can be, and this is a possible pathway. Role models are important. Seeing older students who are not only maybe 3 or 4 years older who are at it is important. That's especially given if you are coming from families when college is a new thing, that no one in this family has ever attended college, which is a large thing. We are in our campuses. It's in the high 30, 40, 50% of students.
Wow, it's amazing. All right, so thank you for that. I'll turn it over to Senator Braun.
Thank you, Mr. Chairman. I'm going to circle back to the structure of the industry again, and my question is going to be for Dr. Flinter. Years ago, we had a lot more hospitals, especially in rural areas. Currently, when you look at the healthcare dollar, 30%, give or take, hospitals, 30%, give or take, practitioners, 15 to 20% pharma, and then insurance. As the stakeholder that pays all the bills in the country, meaning any company that does not is other than a healthcare company, it would be the rest of us employers. And the transparency issue, even when you can self-insure, has been challenging. The other thing is you have fewer options. You've got fewer and fewer hospitals that control a lot of these markets, and even fewer insurance companies. Getting workforce into the nursing side of it, how difficult is it now when it comes to the fact that you end up, unless you have a clinic or you're doing your own thing, which oftentimes the rules and regulations don't make that as easy as it should be, how difficult is it to be a nurse practitioner, not only with the training and the cost of that you're talking about, but in terms of the new structure with the fact that you're working for a hospital? Doctors complain about that often. They used to have their own businesses. Would you want to comment on that a little bit?
Sure. Well, thanks for the opportunity. And it's actually something I've been thinking about quite a bit recently, in part because there's a whole area within nurse practitioner practice of nurse practitioners who are going into entrepreneurial practice on their own. And there's a network set up to support them. And what it reminded me is there probably is a right place for everybody, right? For me, the right place is a structure like a community health center. Takes all comers, regardless of insurance, comprehensive care. There is a trade-off around how much you do individually and how much is organizational policy. But if the organizational policies line up in the direction of the values that it should, that's a plus, not a minus for me. For other people, being an independent entrepreneur or a group nurse practitioner practice, for instance, is the right structure for them. I think people really have to think very critically about their employer, and the right employer is an employer who lines up with your mission, vision, and values for your own career. And I think people are becoming much more savvy about the kind of people, the kind of organization, the kind of structure that they want to practice in. And employers, beware. No matter how big your health system is, you cannot run it without expert people to care for the patients in it. The emerging legislation around transparency and billing, about no surprise billing. You know, we say in community health centers, our patients are the most savvy consumers at all because they are often paying out of pocket as people who are fully uninsured. This is just a part of a fair economy in which we make it clear what those prices are. We make sure that people understand what the deal is, and I think that's true for the people who work in them as well as the people who receive care.
Thank you. Next question for Ms. Gressler. Indiana, I visited last week, and I was shocked that it was only the second one in the U.S. The other one is in Oklahoma City. And this is a group of surgeons that didn't like the idea that their only employment opportunity is now for a huge corporation. Had a vision of having their own shingle hung out there, and increasingly difficult to do. Here is what caught me. So they're going to be a cash-only surgical outpatient center. I said, well, what about inpatient? Oh, there are so many regulations. If doctors wanted to do that, you couldn't even get to first base. Listen to this, on a gallbladder operation. In Indiana, the negotiated rate between insurance companies and hospitals, $22,000. If you come into the system and you just need it and you have no insurance, $32,000. They'll do it for $8,000. And that's going to be the same proportionality on a lot of other surgical procedures. That's entrepreneurialism. That's what we got to do before we start spending more federal dollars in terms of fixing the system. What do you think when it comes to that kind of breaking the system apart? How important is that to fix healthcare in general?
I think that's extremely important because as far as I know, the studies have shown that those smaller practices actually have better outcomes. And there's a lot of broken parts of the healthcare market, but this is one of them where the prices that are charged don't necessarily reflect the services that were provided, the outcome of those services, the amount of time, but they instead reflect insurance codes that they're allowed to bill. And so it is in many ways broken. One thing that could be done is the federal government has a lot of programs. They're in charge of payment rates there. To allow for some innovation and flexibility in those ones. We have seen that doctors and other practitioners that want to move towards having more autonomy and not just having to go by the books of what they're told they can charge and what services they can and can't provide, but just being free to practice as others are in the private sector, not encumbered by all these burdens that are imposed on the healthcare sector.
I think it's a good point, yours as well. I view practitioners and doctors about the same way as farmers in big ag. It's so much different from what it used to be. And whenever we get industries that get too concentrated, the consumer never ends up being in the best place.
On that note, although I think Senator Braun and I could probably spend the next couple hours asking you questions, but I suspect you have other things in your schedule. So I guess that will end our hearing for today. Let me just thank you all, Dr. Flinter, Ms. Quinones, Dr. Verret, Ms. Grissler. I can't remember a more interesting panel and with such clear translation of your experiences in your lives into, I think, really valuable testimony that we will take going forward. If there are other senators who are watching at home and have questions or watching from their office, I shouldn't make jokes about virtual hearings. Questions for the record will be due in 10 business days, so that's on February 24th at 5 o'clock. The hearing record will also remain open until then for members who wish to submit additional materials for the record. The Help Committee will next meet at, shortly in room S127 at noon to mark up several pending nominations, and then again on Tuesday, February 15th at 10 o'clock for a hearing on supporting quality workforce development opportunities and innovation to address barriers to employment. Thank you again for your excellent work today. We stand adjourned.